Well, good day, everybody. My name is Ashley Danker, and I am the clinical nurse educator for Mother, Baby, and GYN in our outreach department here at Methodist Women's Hospital. And I am joined today by my colleagues Kim Diffel and Mary Seeger-Barker, who are helping me present required education by Joint Commission related to postpartum hemorrhage and hypertensive disorders of pregnancy. So to start off today, I wanted to share a little bit with you about maternal mortality and improving maternal outcomes, specifically in the United States. So in order to start and do a good job of setting the groundwork for maternal mortality, it's important that we talk about maternal morbidity, otherwise known as severe maternal morbidity, or SMM would be another abbreviated version that you might see in literature. So severe maternal morbidity in our country is increasing. And number one, it's not entirely clear of why it is increasing, but we do know that changes just generally in our overall population of OB patients is contributing to this increase in numbers. This affects more than 50,000 women per year, and it includes a range of serious pregnancy complications resulting in both short-term and long-term consequences to a woman's health. Some of these reasons, or reasons that could be causing an increase in severe maternal morbidity, include advanced maternal age and an increase in that population that we take care of, pre-pregnancy obesity, pre-existing chronic medical conditions, and then cesarean deliveries as well. You can see here, this is a table from the CDC and documents trends in severe maternal morbidity in our country. And so as you can see in the trends that are shown here on this picture, our rates have increased significantly by up to 75% from when they were first reported around 1998 to 1999. Into the current reported statistics that are from 2014 here on this table. There are significant disparities that exist in our severe maternal morbidity, especially after discharge in patients when we've looked at them long-term, not only their complications during pregnancy itself, but postpartum and after that first year of after delivery. So a significant number of women have severe complications that start after they leave the hospital. When we look at these populations in a little bit more detail, we can find that 1 in 7 severe maternal morbidity cases among commercially insured women occur, and almost 1 in 6 severe maternal morbidity cases occur among Medicaid insured women. And we also see that among Medicaid insured deliveries, Black women are 1.7 times more likely to develop severe maternal mortality than white women. This is a great infographic, and this comes from the CMQCC. I believe it's in part of the education that is developed within their hypertensive disorders of pregnancy. And this is one of their discharge education pamphlets that they provide free of charge that you can utilize with patients. The reason why I have this in here is because I wanted to emphasize the importance and the effect that severe maternal morbidity has on our patients, not just during pregnancy, but after discharge and for the rest of their life. So for example, you can see here, if you had preeclampsia, you have 2 times the risk of stroke, heart muscle damage, or blood clots, and 4 times the risk of developing high blood pressure for the rest of your life. In the middle, in this yellow section, if you had gestational diabetes, you are 50% more likely to develop type 2 diabetes within 5 years, putting you at higher risk for heart disease. And lastly, on the very right in the red section, women with preterm birth and preeclampsia have an 8 to 10 times higher chance of death from heart disease. We'll talk a little bit more about discharge education and how to incorporate these statistics and this risk for your patients in that later on. But right now we're going to move on to maternal mortality and talk a little bit about this in some more detail. So first of all, what is maternal mortality? There are a couple different commonly used measures of maternal deaths in the United States. While they all capture some aspects of maternal deaths, they're not all the same. And so you can see those 3 different commonly used measures listed here. The first is pregnancy-associated death, which is death while a woman is pregnant or within 1 year of the end of pregnancy, irrespective of the cause. Pregnancy-related death is death during pregnancy or within 1 year of the end of pregnancy from a pregnancy-related complication, a chain of events initiated by pregnancy, or the aggravation of an unrelated condition by the physiologic effects of pregnancy. It's a long one. This is the one that's used in the US by the CDC to measure maternal mortality. Typically, it's reported as a ratio per 100,000 births. And then lastly, we have maternal mortality, which is death while pregnant or within 42 days of the end of pregnancy, irrespective of the duration and site of the pregnancy, from any cause related to or aggravated by the pregnancy, or its management, but not from accidental or incidental causes. This one is used by the World Health Organization and is measured similarly to the one above and reported as a ratio per 100,000 births. And one way to differentiate between pregnancy-related death and pregnancy-associated death, those 2 at the top, but not related to death, is to ask the question, would the woman have died if she wasn't pregnant? And if the answer is no, then it is a pregnancy-related death. If the answer is yes, then it is a pregnancy-associated but not related death. And one example of this would be a motor vehicle accident. If a patient is pregnant and dies from a motor vehicle accident as the cause, that would be considered a pregnancy-associated death rather than a pregnancy-related death. The CDC conducts national pregnancy-related mortality surveillance to better understand the risk factors for and causes of pregnancy-related deaths in the United States. And so our pregnancy mortality surveillance system, or PMSS, that defines a pregnancy-related death as a death while pregnant or within 1 year of the end of pregnancy from any cause related to or aggravated by the pregnancy. So as you can see here, on this chart from the CDC, the rates of maternal mortality have increased in the United States since the pregnancy mortality surveillance system was implemented back in 1987. And again, just similar to the severe maternal morbidity, the reason, for this increase is unclear. We have some various speculations and some different things that have been studied in literature, but there's no one concrete answer as to why we're seeing this increase. Some speculation is that the increase is a result of improved identification of pregnancy-related deaths. This includes changing how maternal deaths are coded, how they're linked to death records, etc. And we'll talk about a few more of those reasons here in just a moment. I'm going to pause. Sorry, Rachel, delete this section too, so I can go sit back down and see if my clicker works. Yay! Okay. I'm going to sit my butt back down.
Was it plugged into the PC?
It was. It just went.
No, the one we was sitting on the desk.
Oh.
A computer stand. So somebody had to take it out to put childbirth ed clicker in. So they just set it up on top. So we must have left it in.
Forgot to take it.
Shoot.
Well, okay, resuming. So where do we stand in comparison to other countries in regards to maternal mortality rates, specifically developed countries? This graph from the Commonwealth Fund has done research to measure this and demonstrates that we in the United States have the highest maternal mortality among developed countries. There are other factors that, besides just the death reporting and coding, that have been thought to contribute to the high number of maternal deaths in the United States. Some of this includes too few maternity care providers, especially midwives. We see maternity care deserts, specifically in areas, even just here in Nebraska, where OB care is not provided or not easily accessible to patients. We see areas where OBGYNs are overrepresented in maternity care workforce relative to midwives, or there's a shortage of maternity care providers in general relative to births. And that's why there's been an emphasis, even in the last year, on including and incorporating midwifery and doulas into the OB care that patients receive. that's in response to these statistics. In most other countries, midwives outnumber OBGYNs by several fold, and primary care plays a central role in the healthcare system. Another reason is lack of access to comprehensive postpartum support. Although a large share of maternal deaths occur after delivery, the U.S. is the only country not to guarantee access to a provider home visit or paid parental leave in the postpartum period, which is thought to contribute to these rates as well. Okay, so I spoke about midwives just a little bit previously, but we're going to talk about that in a little bit more detail here just for a moment. So the United States and Canada have the lowest overall supply of OB providers, both OBGYNs and midwives. All other countries have 2 to 6 times higher of supply. You can see this in comparison to other developed countries, both for OBGYNs and for midwives as well. Midwives in other countries, especially those that have the higher rates shown on this graph, are key care providers trained to provide a wide range of services for patients. They help manage a normal pregnancy, they help assist with childbirth, they provide care during the postpartum period, and they place a priority on natural reproduction processes and relationship building. They also can help address the social and personal needs of mothers, babies, and families at those comprehensive postpartum visits. OBGYNs, while super valuable, they are trained to identify and intervene in abnormal conditions that come up before, during, and after pregnancy. They typically provide care in hospital-based settings rather than in the home-based setting. Several systematic reviews have found that midwifery care for women, with healthy pregnancies is comparable or preferable to physician-led care in terms of maternal and neonatal outcomes, including lower maternal mortality, morbidity, decreased stillbirths and preterm deliveries, more efficient use of healthcare system resources, lower use of unnecessary and potentially harmful interventions during OB care, and improved patient satisfaction and maternal psychosocial well-being outcomes. And we'll look at mental health specifically in a moment and talk about that in a little bit more detail. Some experts note that high-income countries with the lowest intervention rates, best outcomes, and lowest costs have integrated midwifery-led care into their healthcare systems. And you can see that specifically with Sweden in general. Even if we just go back one slide and look for a moment at this graph, they are one of the lowest countries in regards to maternal mortality rates. And they are the country with the highest ratio of midwives per live births on this table. Next, I alluded to postpartum care, and we know that postpartum care in our country is lacking. I'm sure this is not a surprise. Access to home visits after delivery varies in the United States, but it's guaranteed in all other countries that are listed on here, those that are developed and comparable to the United States. Home visits by a midwife or a nurse are associated with improved mental health, with breastfeeding outcomes, and as well as reduced healthcare costs. There are some states, I will say, that do provide home visits in terms of Medicare benefits to patients, but that's not a guarantee for all patients or an equitable resource that's currently offered to our OB patients in our country. Since more than half of maternal deaths occur after birth, strengthening postpartum care should be a priority. And the World Health Organization addresses this by specifically recommending at least 4 health contacts in the first 6 weeks after delivery. However, in the United States, women typically have a single office-based physician visit within this period. And if we were talking about ACOG guidelines yesterday, if following ACOG guidelines, they would receive 2 contacts, one being a phone call, and the second required to be seen in the office. So definitely lacking in comparison to other countries. Next is the maternity leave. The United States is the only high-income country that does not guarantee paid leave to mothers after childbirth. And we know that maternity leave, it helps women and families manage the psychological and the physiological demands of motherhood and parenthood. It helps ensure financial security for families as they adjust to having a new baby and to their new role as parents. All countries included in the study, apart from the United States, mandate at least 14 weeks of paid leave from work. And several countries that are listed on this graph provide more than a year of maternity leave. So we definitely have some room for improvement. When we look at maternal mortality and look at the disparities that exist, there are considerable racial and ethnic disparities in pregnancy-related mortality in our country specifically. And this is seen internationally as well. But looking at the United States, you can see our rates of maternal mortality in comparison with non-Hispanic, Native, Hawaiian, or other Pacific Islanders, non-Hispanic Black patients, non-Hispanic American Indian or Alaska Native, non-Hispanic White, non-Hispanic Asian versus Hispanic patients. Data confirms that significantly higher pregnancy-related mortality ratios among Black and American Indian and Alaska Native women exist. And when they looked at these gaps over time, looking at the past several years, and comparing maternal mortality for these populations, the gaps did not change over time. They remain the same. We also know statistically that Black women with higher incomes and college education have worse health outcomes than white women who have not graduated from high school, and that younger age, higher socioeconomic status, and education level do not reduce maternal mortality rates among Black women. In terms of discrimination, there have been studies that have documented that discrimination contributes to maternal mortality in our country. And this is from the most recent Maternal Mortality Review Committee report that was released last year. And they looked at and decided to determine whether discrimination contributed to the death of a mother, or just whether the individual was exposed to discrimination. And you can see those statistics are demonstrated on this infographic here. They define discrimination as treating someone less or more favorably based on the group, class, or category they belong to, resulting from biases, prejudices, and stereotyping. We know that discrimination can manifest as differences in care, clinical communication, and shared decision-making, and they looked at all of these things and evaluated them when doing case reviews for patients in their mortality review committees. In 2020, it was determined to add this determination as an option for maternal mortality review committees to review. And so this is the first time that this was reported on this review, and these rates are from our most recently reported dates from 2017 to 2019. As you can see, the committees determined that discrimination is a circumstance that contributed, yes, or probably, to 30% of maternal mortality deaths in our country during that time. When we look at the timing of pregnancy-related death in the United States, this is a great graph that shows that breakdown for you. 22% of maternal mortality deaths occurred during pregnancy, 13% occurred the day of delivery, and then the remaining percentage occurred during the postpartum period, with the majority occurring after 43 days postpartum and up to 1 year after birth. When we look at the causes of pregnancy-related death, there's a couple different graphs that I'm going to show you. This first one is from the CDC's maternal mortality statistics that are reported on their website, and that is on the references if you'd like to go there and look for yourself. But you can see these are from our most recently reported statistics, the same time frame that's in that Maternal Mortality Review Committee's time frame from 2017 to 2019, and it shows the rates and causes of pregnancy-related death in our country. Now, interestingly, this data is pulled from the coding and the death certificates from patients when they do reviews of all pregnancy-related deaths. Now, when the maternal mortality review committees, which are they look at residents of 36 states that are currently participating in this review committees, this is what they determined and found for patients. So there's a little bit of a variance between the causes of pregnancy-related deaths when they looked at specific cases for these patients compared with overall death reports and certificates. The maternal mortality review committees, those are multidisciplinary committees that meet together at the state or local level to comprehensively review pregnancy-associated deaths that occurred, like I said, among those residents of 36 currently participating states. The committees include representatives from all different areas, so it's interdisciplinary, including public health, obstetrics, gynecology, maternal fetal medicine, nursing, midwifery, forensic pathology, mental and behavioral health, patient advocacy, and various community organizations as well. They review clinical and non-clinical information, so they look at vital records, medical records, social service records in relation to patients, OB patients. And their hope is to better understand the circumstances that surround each maternal death. Then they decide or look at determining whether the death was pregnancy related, and they develop recommendations for action to prevent similar deaths in the future. The data is then shared with the CDC, who works with the maternal mortality review committees to improve and review processes that inform recommendations for preventing future maternal deaths. So the difference, I would say the main difference on here that I just wanted to emphasize and point out is the inclusion of maternal mental health conditions versus the slide before that is currently not an option to select when on maternal death codes or on death certificates. And so it's not included, I'll go back for a moment, not included on this general CDC slide from the causes of pregnancy-related death. But when looking at those cases and breaking down the cases and doing specific case reviews for all of those in those 36 states, they did start to include maternal mental health conditions, which has been shown to be the leading cause of maternal mortality in our country. I will say specifically, just to clarify, for the mental health conditions, this does include deaths related to suicide, overdose, and poisoning related to substance use disorders, and other deaths determined by the mortality review committees to be related to a mental health condition, including substance use disorder. It does not include unintentional injury, including overdose or poisoning deaths not related to substance use disorder. Those would fall into the injury category that's shown down the line. Okay, so how can we do better? I've given you a lot of negative statistics, so sorry. But we're going to talk just a little bit about how we can do better and how you can make a difference in the care that you provide to your patients. So first off, this is encouraging to me. Maternal mortality is preventable. And we, in the most recent review committee report that was released, it was shown that more than 80% of pregnancy-related deaths were preventable. So we can make a difference in a majority of our patients. And a lot of times it does start with nursing and the care that you provide at the bedside, which is so important that you are listening and understanding. And eventually we'll listen to Mary and Kim talk about two of the main causes of maternal mortality and how you can do better in caring for those patients as well. When those review committees look at the cases and determine, number one, were these cases preventable in maternal mortality? And also they look at areas that could be improved in the care that was provided to those patients. They divide that improvement up into different categories, and we call those the 5 R's to address maternal morbidity and mortality. So in each case that's reviewed, they look at did readiness exist? Was the nurse or the healthcare providers, were they ready to care for those patients? Was the unit ready to care for those patients and to overcome and to address the maternal morbidity that the patient was experiencing at that time, or the complication they were experiencing at that time? Then they look at recognition and prevention. I'll go back for just a minute. Readiness includes some examples of that would be bundles that you would institute in your facility that would help you respond to every patient, for example, who is hemorrhaging with the same response every time. That would include like a hemorrhage cart, a bundle with standardized medications, a standardized response to getting staff on the unit. Maybe you have an OB hemorrhage RRT call or a general RRT call or anything of that like. Those would all be measures that are put into place to help you be ready to respond to a patient. Then the second thing that they look at is recognition and prevention. And this is for every patient as well. So not only is the unit ready, but were the healthcare providers taking care of that patient? Were they ready to recognize the complication that was occurring with that patient and possibly to prevent it as well? The next one, the third one, is response. So when a patient comes in, for example, I use hemorrhage, was not only the unit ready, did they recognize that that patient was hemorrhaging? Were they able to respond to that patient appropriately and in a timely manner? The next is reporting and systems learning. And so this is some of that going back and reevaluating. Was it reported to the correct healthcare professionals? Did the systems work appropriately in response to the EMR and alerts that are occurring and a chain of command, et cetera? And then lastly, was the care that the patient received respectful, equitable, and supportive? And this is for every unit, every healthcare provider, and every team member. Did they all experience those same R's? So those are the ones that we look at. And those 5 areas specifically have been shown in literature to significantly, or have the potential to significantly decrease maternal mortality rates in our country. And Mary and Kim will talk specifically about those different areas and how to incorporate them in relation to postpartum hemorrhage and hypertensive disorders of pregnancy. I did mention a little bit about the postpartum care that we need to do a better job of improving. One of the ways that we can do that is through amping up and doing a better job of providing comprehensive discharge education to our patients after delivery and to their families and those that would be supporting them at home. Early recognition of maternal complications is super essential. It's critical. Patients need consistent, comprehensive, evidence-based discharge instructions. Every patient, every time, the same instructions. Women who can recognize signs and symptoms and understand explanations offered are more likely to report concerning symptoms and comply with prescribed treatments. And then on the flip side, physicians or healthcare providers who consistently explain signs and symptoms to patients are more likely to respond appropriately when that OB patient reports those concerning signs and symptoms. And I will tell you, in a lot of the case reviews that they have done, looking back, that is where a lot of the gaps have occurred in recognizing signs and symptoms, both in healthcare providers and patients, and also listening to patients when they tell a healthcare provider that something is wrong or they feel like something is not right. There are some tips when providing discharge education to your patients. I'm going to backtrack just for a minute, but really important just to emphasize, I know I'm postpartum, that's my specialty. So this is kind of an area of passion for me. But when we look at our postpartum care and the statistics that I presented, our patients are seen one time typically in their postpartum period. Sometimes 2 or a couple more if they're at high risk, but rarely do we see them or do any follow-up after 6 weeks. And when I gave you the statistics and the data to show that the highest rate of maternal mortality, that occurs between 4 to 6 weeks and a year after delivery, at the time when we're not seeing patients and we're not connected to them anymore. And so this is why discharge education is so important. You are equipping and training your patients to know how to advocate for themselves, to be aware for signs and symptoms that are concerning, and to be able to contact their healthcare provider and notify them of those early on before it's too late, so that we can intervene and hopefully prevent maternal mortality. So when you're giving that discharge education, there is specific criteria that's been shown in literature to be helpful. Number 1, use lay terms. Don't assume that your patient knows what she needs to know. Give her all the information, repeat it multiple times, teach it to her support system and to her family, use plain language. For example, saying high blood pressure rather than hypertension, or seeing sparkles or seeing dark spots in your vision versus visual disturbances. So use those basic terminology. Be really clear in what you're explaining. Make sure that your patient knows the symptoms and knows what to do if they're experiencing any of them. And this has to be repeated. It can't just be introduced one time on discharge for a patient and a family member to remember. You've got to start at the beginning on admission and repeat. When I teach nurses this in one of our other classes, I emphasize that when I do my head to toe assessment, I walk through with my patient when I'm doing my assessment. I tell them what I'm assessing for, what it's a sign and symptom of if something were to come up, why it's concerning, and who they would need to call if it happens at home. And I try and repeat that multiple times. Assess the patient's understanding. So rather than asking, do you have any symptoms to report? Try asking them, have you experienced any change in your eyesight? Or have you had any really bad headaches that won't go away even with rest and medication and hydration? Or increasing your water intake. You can ask your patient what they would do if they experience any of those symptoms. So if, for example, if you have a headache that doesn't go away with rest and pain medication, and increasing your water intake, what would you do when you go home? Have them regurgitate back to you what their call to action would be and their response would be. Make sure they know if it's appropriate to call, leave a message on a nurse line with a provider, or if they need to be seen emergently in the ED. These are just some examples of the standardized education post-birth warning signs or urgent maternal warning signs that are available to patients that you take care of. And there's a couple more, so I'll just kind of scroll down so you can see the next two. The one on the far right, this post-birth warning signs, this is the one that we're currently utilizing in our healthcare system. It was developed based on AWHONS post-birth warning signs on the previous slide that I showed. None of these are better or worse than the other. They're all pretty similar. They offer the same baseline for the warning signs and when a patient would need to call a provider, and all would be appropriate for to utilize in your healthcare system. The important thing is that you give them a printed handout that they can go back and reference to, because they won't remember everything that you're telling them. So to have that handout to refer back to is really important. They can also bring it with them as a backup or as a resource when they're advocating in the ED for care for themselves or advocating in their healthcare provider's office. This will give them additional clout to emphasize the importance that they need to be seen and taken care of. Okay, so then moving on, transitioning a little bit more. So not in addition to increasing our discharge education and the support that we give to patients after discharge, as well as increasing our preparedness with those 5 R's to respond to maternal complications in the hospital, there's other things that we can do to improve the care that is provided to our maternal patients, and to decrease maternal mortality. And if you remember that infographic that I brought up related to discrimination, that Maternal Mortality Review Committee, they determined that 30% of pregnancy-related deaths were either contributed or probably contributed to discrimination that patients received in the care that was provided. And that is just inexcusable to me. So we can do so much better. AWHON has done an excellent job of developing education and a toolkit and a bundle that can be utilized both in your own personal practice and in the healthcare system in which you work, in response to the need for increased respectful maternity care for our OB patients. They have emphasized the need to address maternity care disparities, specifically the role that discrimination and bias play in equitable treatment for all women, as well as the knowledge and actions needed to transform maternal health care in the United States. And respectful maternity care, it describes a basic human right and an optimal strategy to ensure that all women receive equitable maternity care free from abuse and disrespect. So what are the basic rights of respectful maternity care? And we'll kind of go through these in a little bit more detail, but just as an overall picture, these basic rights include freedom from harm and mistreatment, patient autonomy, patient and provider relationships rooted in mutual trust and respect, accountability of the healthcare team and organization, informed consent, access to best available treatments and modalities, and maintenance of patient dignity. We know that when loss of autonomy, dehumanization, and physical and emotional traumatization occur in the healthcare setting, there are lasting impacts not only on a patient's health and well-being physically, but on their mental health and future patient-provider interactions that would happen for the rest of their life. To quote AWHON in their bundle, a study done by Mick Lamore and colleagues highlighted the importance of trusting the patient as an expert of their own body and health to improve maternal outcomes. Healthcare providers should use evidence to expand their approaches to care, which include advocating for the values of patients to create a foundation of shared decision-making. It's one's human right to have a voice in their well-being and to be treated with dignity. And that's kind of the foundation of this bundle and toolkit. So what affects the care that's provided? There's a lot of you can see these different categories that show the type and level of care offered by providers and the influence that it can have based on influential factors such as organizational structure, the culture of the organization, obligation to comply with practice policies, staffing, time constraints, level and type of professional training, personal experiences, etc. Organizational culture and availability of resources influence providers' ability to deliver respectful care. The The healthcare environment and policy should be structured to support clinicians in providing respectful maternity care. And standardized guidelines that reflect equitable access to respectful care are essential. And really, that's the foundation for developing these bundles that we'll talk about and standardized responses to common causes of maternal mortality. Is it's meant to be equitable. Every patient gets the same response and the same treatment every time. A lack of resources and interventions, including access to services, can decrease respectful maternity care that's provided to patients. Over medicalized care or too much interventions before it's necessary can contribute to increase in maternal mortality and morbidity, and then dissatisfaction with the overall birth experience with our patients. Provider attitudes and behaviors rooted in cultural norms and bias can hinder patient access to respectful maternity care. Unaddressed biases can contribute to providers causing harm to patients. Discriminatory behaviors upheld by providers can diminish patient dignity and respect. And attitudes rooted in racism and other forms of antagonism can place patients at increased risk for not receiving quality of care. A patient's own history of personal experience and personal expectations and their life experiences. So that would be, their culture, their traditions, their beliefs, values, their knowledge of the healthcare system. Those can all affect the patient and provider relationship as well. We know that there are some groups of individuals that are at risk of decreased respectful maternity care, and I showed you those populations when we did some of the statistics earlier. Factors protecting against respectful maternity care, ethical violation, and mistreatment include being white, having a vaginal birth, giving birth at home or in a freestanding birth center, having a midwife provider, having an infant after the age of 30 years, and being a multip. Okay, so the first one, talking about awareness. This is the state of being conscious of potential biases with the intent of using this consciousness as a platform to address biases to optimize patient-provider relationship and improve care. As healthcare providers, we hold strong beliefs toward or against certain birth practices, even when there's no evidence of harm for some practices. These biases or judgments are easy for patients to detect. They are observant, they can sense them, they can feel them. And a clinician's negative perception can result in pressuring or coercing patients to make a decision based on the provider's preference instead of their own. Biases can undermine true shared decision-making, patient autonomy, and choice, and feeling supported by the healthcare team. So to provide respectful care, as a nurse or healthcare provider, you should be aware of your patient's previous pregnancies, what their childbirth experiences were. You should listen to their concerns and their decisions, understand how past experiences led them to the place that they're at and the decisions they're currently making. Work towards building trust, especially among mothers with a history of traumatic birth. It's really important, too, to be aware of your own physiologies or philosophies of birth, and your own perspective on specific birth practices. So a good example would be women and providers may vary highly in their tolerance for risks and potential complications of a particular procedure. Providers can be strongly biased in favor of interventions such as an epidural, which can undermine a patient's role in informed decision-making. And we all have these. We carry them with us based on our own personal experience, the research that we've done, all those different things. And it's important to set those aside and really consider, what is your patient desire? What have their past experiences brought to the table? And how can you support their desires and give them a positive birth experience? So some of the questions that you can ask would be, what are your own philosophies of birth and associated practices? What things do you bring to the table, your opinions, your beliefs, et cetera, that can impact the care that you provide to your patient? And then what are your patient's previous pregnancy and birth experiences? And it is not just a labor and delivery nurse's responsibility to ask these. I would say that this is something that's the responsibility of all healthcare providers that are taking care of an OB patient. Really being attuned to understanding what their previous experiences were, if they have any trauma or negative experiences related to that. And then how can you do a better job of protecting them from reliving that experience again with a consecutive birth. Mutual respect is the reciprocal process in which two or more individuals or groups honor the other by exhibiting care, concern, or consideration for the other's needs or feelings. There's a lot of different ways that we can develop mutual trust with our patients. The first, I would say, that's most important is taking the time to sit and talk and listen to your patients. Listen to them. When patients are ignored or their concerns are discounted, they feel dehumanized or like they're a number or a statistic, that they're not valued as a human being. Some women are specifically at risk for having their concerns minimalized, especially those with past birth trauma or experiences of being left alone or not listened to or violated, may choose options contrary to medical advice because they don't want to repeat those same negative experiences they had in the past. Patient-centered communication includes getting to know what your patient's preferences are, asking them questions about what they value, what they're choosing for their OB care, et cetera. And so some of the things that you can ask to ensure that you're providing mutual respect and developing this with your patient would be, what are their concerns? What are their requests? What are their preferences? What do they value? Does your patient have any questions or concerns? And are your patient's needs being met? And that's a simple question that you can ask them. Do you feel like your OB care needs are being met? And if the answer is no, then as a nurse at taking care of you, how can I do a better job of ensuring this? How can I advocate for you in that regard? There's other strategies to establish mutual respect with your patient. Some of this is birth partnership planning. Some of the things that you might ask or address would be, who does the patient want to be with her in labor and delivery? Who does she want to be with her in the postpartum period? What would help your patient feel confident and relaxed? What resources do they want available for comfort and support? Are there specific forms of treatment they do not or do want, and why? What is the reason for that? If labor doesn't go as expected, how will the patient address their options for interventions? So having that conversation early is important. And then how does the patient want to initially interact with their baby? What preferences does she have for bonding, for feeding, for care after birth? And all of those things are important to talk about ahead of time. Effective patient-centered communication is utilizing clear explanations, acknowledging past experiences that your patient has had, and responding to questions with open, realistic, and honest answers. It's really helpful if you can ask open-ended questions and then really use your poker face to respond without judgment. Let your patient explain to you why they've come to the decisions that they've made and the purpose for those decisions. Take your time to acknowledge and support your patient's specific cultural beliefs and practices, and then echo the language that's used by your patient. And then lastly, for that mutual trust, talking with your patient and not about them when you're in your patient's presence is really important. So if you're at the bedside, you're talking with a provider, you're including your patient in that conversation. You're not talking about the patient in front of them. Giving mothers your full attention, actively listening to patients by matching nonverbal communication, eye contact, sitting down at their eye level, matching their verbal communication, et cetera, is important. You can assess your patient's verbal and nonverbal communication for signs that they're developing trust in you and the healthcare team. You can take time to make small talk and get to know the patient and family, and then approach each circumstance with positivity, information, and hopefulness. Okay, more specifically on shared decision making. So this is the communication process in which two or more individuals or groups work together to make optimal healthcare decisions that align with goals and values of the patient, taking into consideration the best available evidence to support the decision. Some of the things that you can ask when participating in shared decision making with your patient would be, did you provide accurate, unbiased, evidence-based information to your patient? Those biases that we talked about earlier about your own OB care or your opinions on OB care and interventions, did you leave them at the door, at the beds, or at the table, and then come unbiased when you had that discussion with patients? Does your patient know all available options? Does she know she can decline care or defer decisions if she's not ready to make one at that time? And did you recognize and respect your patient's goals, values, and preferences in the decision-making process? All clinicians should strive to consistently use a shared decision-making process made up of three critical elements. The first is accurate, unbiased, evidence-based information regarding all available options, not just the one that you prefer or believe is best. An engaged provider who is skilled in communication and able to individualize care for the patient, and a patient whose values, goals, preferences, and contexts are recognized and respected as part of the decision-making process. That leads us into informed consent. Informed consent is the voluntary decision of the patient regarding care or treatment after having been given adequate, accurate, and understandable information concerning the treatment options and their important benefits and risks. So when asking if you're doing an adequate job of providing informed consent, things that you can evaluate would be, have you provided sufficient information for your patients to fully participate in making decisions? Does the final decision lie with your patient? Do you respect her decision, whether she agrees with you or not? Are the interventions recommended by to your patient well supported by evidence, and are they necessary? Autonomy. This is the core ethical principle in maternity care. It refers to the right and ability of individuals to make self-governed decisions about their health and health care. Maintaining both perceived and real control over care is very critical to women's experiences, and loss of control is a significant contributing factor to traumatic birth experiences and then PTSD after delivery in the postpartum period, and honestly, well into women's life. Ways that you can do this is demonstrating support for the patient's individual choices by explaining information and options calmly, using neutral language, avoiding judgment, coercion, blame, or trivializing your patient's concerns. Questions that you can ask to ensure that you're providing autonomy to your patients would be, does your patient feel she has maintained control over her care? And if the answer is no, then what are you doing to address that? What are ways that you can give back autonomy to her? Have you explained information and options calmly using neutral language? Have you avoided making judgments with your patient and their care that's provided or their situation? And does your patient feel her concerns are important and valued? We're almost done. Couple more. Dignity is the ethical assertion that each person has inherent worth and value as a human being. Patients must be treated so that they are able to feel, think, and behave in relation to their own worth or value. Beyond ensuring access to safe care in the healthcare setting, delivering dignified maternity care has become a major focus of respectful maternity care, not just in our country, but in human rights work around the world. When dignity is fully protected, all staff will listen to and take seriously the concerns of patients and their support persons when those concerns are raised with the healthcare provider. Disrespect in the context of obstetric care is defined as the violation of a woman's dignity as a person and as a human being on the basis of her economic status, gender, caste, race, ethnicity, marital status, disability, sexual orientation, or gender identity. And the process of labor and birth can be marked as one of vulnerability in which a pregnant person experiences a variety of assessments and interventions that are intimate and invasive. This lack of privacy or non-confidential care is experienced as a violation of rights and it can be considered a form of mistreatment or abuse for our patients. So it's very important that we respect and maintain their dignity. So some things that you can think of or questions that you can ask to ensure that you're doing this in the care that you provide is looking at, have you created a birth environment that's comforting and free from distractions? Have you ensured that all patients are provided personal privacy? This can be as simple as closing curtains and doors when you're assessing a patient and you're in the room, knocking, announcing your presence, and then waiting for your patient to give you the okay before you come in the door and enter the room, giving them adequate clothing to cover exposed body parts, making sure that you're protecting that as well during assessments and interventions. Have you ensured that all patients are provided personal privacy, and do you seek and document patient permission before disclosing any information? And then lastly, accountability. This is the process of acknowledging and taking responsibility for your actions, including when they're harmful to somebody else. And ways that you can ensure, questions that you can ask to know if you are being held accountable and providing this would be to look at, have you received formal training on communication techniques, shared decision-making, and obstetric violence? So things we're talking about right now, this is an introduction. This is not comprehensive by any means, but does it spark a question in you? Have you received formal training on these topics that we're discussing? And if not, A1 provides them for you. If you're a member, you can access those for free, or you can, I think you can pay if you're not a member, right? Yeah, to access it anyways. So this is available on the website, and I'll show you what that looks like in just a moment. Have you documented information about your patient's identity, care preferences, specific needs? And did you communicate this to the healthcare members of the team? And then lastly, does your workplace have a formal system for debriefing after emergencies and adverse incidences? And that's part of those bundles and response in the R's. And Mary and Kim will talk about those in relation to those specific maternal mortality causes that we'll discuss later. So these are two of the handouts that are available on A1. The first on the left is for patients, and it goes through those different those different categories that are essential to respectful maternity care that we just discussed pretty briefly. And the right is for nurses. And it gives just some background to those same categories, and it gives just a little bit of information related to those core elements and how you can integrate those into the care that you provide to your patients. Okay, so lastly, we've talked about how we can improve our readiness and our response when a patient presents in the healthcare system with maternal complications. We've talked about how we can improve our discharge, postpartum discharge education to hopefully identify and decrease maternal mortality in the postpartum period. We've discussed how we can provide respectful maternity care to our patients, our OB patients, when they're in the healthcare system during pregnancy and postpartum. And then lastly, we are going to discuss just briefly Joint Commission and what's required of us as OB providers to hopefully help decrease the rates of maternal mortality in our country. So in July of 2020, there was 13 new elements of performance that were applicable to Joint Commission accredited hospitals. And these new requirements are within the provision of care, treatment, and services chapter, those those measures. They're designed to improve the quality and safety of care provided to women during all stages of pregnancy and postpartum. So one thing, this is required that all organizations that provide obstetric services receive standardized education related to postpartum hemorrhage and to hypertensive disorders of pregnancy, in addition to some other standards, and I'll show you those in just a moment. Organizations that don't provide obstetric services, they do not have to comply with some of the standards related to postpartum hemorrhage, because typically that would occur when a patient is on an obstetric unit. However, they do have to apply with the standard that requires the development of role-specific education for postpartum severe hypertension and preeclampsia for emergency department staff. So that's one difference between depending on what kind of facility you work at and the education that you may receive. So you can see here, this is the standard PC related to maternal hemorrhage. There is a full list of details, the EPs, those little details that are required in the standard PC, but the ones I've emphasized are what we're trying to meet for you today in the education that Kim and Mary will be presenting. First is to provide role-specific education to all staff and providers who treat pregnant and postpartum patients about the organization's hemorrhage procedure. At a minimum, education occurs at orientation and whenever changes or processes occur in every 2 years. And then to conduct drills at least annually to determine system issues as part of ongoing quality improvement efforts. So our goal with our education is to meet this standard number 4, this goal, to give you that annual or every 2-year education that's required related to postpartum hemorrhage. We also want to prepare you to meet this standard, the EP7, which is to provide education to patients and their families, including the designated support persons whenever possible. At a minimum, this would include signs and symptoms of postpartum hemorrhage and signs and symptoms of hemorrhage that would alert the patient to seek care after discharge. Next is the standard related to maternal severe hypertension or preeclampsia. Ooh, my letters are messed up, so sorry about that. And this is the same, to provide role-specific education and to conduct drills annually. So we're hoping that we can meet that need for you for your annual education and every 2-year follow-up education. In addition to your requirement to provide printed education to your patients and to educate them on adequate discharge instructions related to maternal severe hypertension and preeclampsia.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.